In this module, we'll discuss specific therapies in development for asthma, and we'll also address persistent questions in the treatment of severe asthma, such as long-term treatment with biologics and the potential for combination therapy. And we'll provide some summary takeaways. One of the most interesting developments in the management of severe asthma has been the consideration of use of antibiotics in the management of patients with severe asthma. Antibiotics that are effective against atypical bacteria may have anti-inflammatory activity, and several studies have been done showing that use of macrolide antibiotics, such as azithromycin, or ketolide antibiotics, such as telithromycin, may have benefits in patients with severe asthma. In one of the most recent studies, the AMAZES study, published by Gibson and colleagues in 2017, demonstrated a beneficial effect of azithromycin on asthma exacerbations. In a study that enrolled 420 subjects, individuals were randomly assigned to receive azithromycin 500 milligrams 3 times a week versus placebo for 48 weeks. In this study, azithromycin reduced asthma exacerbations and significantly improved asthma-related quality of life. The reduction in exacerbations was on the order of about 40%, similar to many of the biologics that have been studied. Not only that, but there was reported benefits in both eosinophilic as well as non-eosinophilic subtypes of asthma. And thus, many patients are being evaluated for consideration of use of a macrolide antibiotic such as azithromycin in patients with severe asthma. Also on the horizon is an important therapy that targets TSLP, thymic stromal lymphopoietin. Tezepelumab is currently in phase 3 studies that are currently in recruitment, but a phase 2b study that was published in 2017 by Jonathan Corren in the New England Journal of Medicine showed that tezepelumab was effective in terms of reducing asthma exacerbations across all patient groups, both type 2 asthma as well as non-type 2 asthma. And the reduction in exacerbations was seen at a range of approximately 70%. This therapy, administered subcutaneously, 70 milligrams every 4 weeks, with dosing up to 280 milligrams every 2 weeks, demonstrated that patients who received tezepelumab had benefits across a variety of outcomes. In particular, more patients in tezepelumab groups were demonstrated to achieve well-controlled or at least partially controlled asthma at 52 weeks versus placebo. It's exciting to see what will happen with tezepelumab as phase 3 studies are completed. It's exciting that there are several other emerging target-specific therapies. One of the most exciting and newest therapies in development are Crt H2 antagonists that block the prostaglandin D2 receptor. One of the therapies in the Crt H2 categories that's furthest along in development is fevipiprant. This has shown promising results in cellular, functional, and clinical outcome studies and has been demonstrated to have acceptable safety. It's been shown to decrease prostaglandin D2-mediated eosinophil migration, and in patients with eosinophilic asthma, it's been shown to improve lung function and symptoms. One of the most exciting components of fevipiprant is that it's an oral therapy, and so may be considered to be used prior to use of other biologic agents. It's currently in phase 3 development, and it will be interesting to see what emerges from those data. The biggest unmet need in asthma is probably, however, therapies that target non-type 2 inflammation. We already have therapies that target type 2 inflammation, including those that bind IL-5, IL-4 receptor, and IgE. So what we need are therapies that target non-type 2 inflammation. Currently in development are Crt antagonists that decrease IL-8 levels. These have shown promise in early trials. Navarixin reduced sputum and blood neutrophils, and there was a trend towards better asthma control based on asthma control questionnaire, but there was no significant change in lung function. Another potential target are IL-6 antagonists. Interleukin 6 is a potential biomarker of systemic inflammation, and along with C-reactive protein, may be a biomarker of non-type 2 mediated severe asthma, particularly in patients who have obesity-associated asthma. There are currently interleukin-6 therapies that are available for other indications, but studies are needed and are initiating in patients with severe non-type 2 asthma. Another important therapy that's in development for non-type 2 asthma is interleukin-17 antagonists. Brodalumab was one therapy that was evaluated. It didn't achieve significant clinical benefit, but perhaps not the right patients were selected in the limited study published by Bussey and colleagues. Other therapies that target asthma pathways a bit more proximally include therapies that target interleukin-33 and interleukin-25, so-called alarmins, that along with TSLP activate a broad range of cells and a broad range of cytokines. These therapies are both currently in development in phase 2 and are exciting and may show significant promise in the future. While it's exciting to have newly available therapies that target specific pathways for severe asthma, many questions persist regarding their use. In particular, how do we decide between biologics that target the same pathway? How do we decide between mepolizumab, reslizumab, and benralizumab? Is it based on dosing strategy? Is it based on patient preference? Or are there specific biomarkers that can help us decide between one therapy versus another? Furthermore, how do we decide between biologics for patients that meet criteria for different therapies? How do we decide between anti-IL-5 therapies, anti-IgE therapies, and anti-IL-4 antagonists? All of these therapies compete in the type 2 anti-inflammatory space. And how do we decide which drug is best for which patient? Should we be combining biologics for these patients? Perhaps some patients have both IL-5-mediated inflammation and IL-4-mediated inflammation and may benefit from blockade of both of these two different cytokines. Perhaps patients have both IL-4-mediated inflammation and IgE-mediated inflammation and may benefit from each of those different types of treatment strategies. Another question that emerges is how long should we treat our patients with these biologics? 6 months, 12 months, forever? We don't have answers to many of these questions, but we need to do further research to address some of these issues. We need to do head-to-head studies, and we need to do studies in which we treat patients who are doing well with these therapies and randomize them to continue therapy or stop therapy to decide how long we should treat them for. Another question that emerges is, should we be giving biologics earlier in the treatment paradigm? Is it important to perhaps give these biologics to address the underlying asthma pathophysiology and overall asthma treatment course? Can we affect long-term asthma development by either giving these drugs earlier on with patients with milder asthma or at younger ages to infants and children who may be at risk for developing asthma down the road? Clearly, a lot of research is needed. We need to determine the optimal duration of biologic treatment. We need to evaluate long-term safety effects of treatment with biologics. We need to evaluate the risk of relapse on withdrawal of these therapies. And we need more research on biomarkers to assess treatment response, identification of newer biologics, and to help us decide which drug is right for which patient. We also need to develop newer therapies for patients with non-type 2 asthma and non-eosinophilic asthma. That, I would say, is probably the biggest unmet need because there are no therapies right now for those patients. Today, we have a better understanding of underlying disease mechanisms of asthma, and we've recognized the importance of using biomarkers and endotypes to personalize our treatment approach to patients with severe asthma. We've made many advances in the treatment of severe asthma, and this has resulted in evidence-based treatment guidelines. And we now have evidence about specific phenotypic patterns that track with different endotypes. We also have an increased understanding of biomarkers and their use in treatment selection. We now have the capacity to screen patients to choose the right therapy for the right patient at the right time. Clearly, biomarkers are needed to identify the most appropriate therapeutic strategy for a specific patient, and new biomarkers are needed. It's an exciting time for the management of patients with severe asthma. We have new therapies, we're understanding our disease better, and hopefully we'll be able to have a huge impact on the management of patients with severe asthma down the road for both type 2 asthma as well as non-type 2 asthma. Thank you for joining us today in our program entitled Advancing Knowledge to Practice, Optimizing Severe Asthma Care in the Age of Biologics.